Welcome to this video on imaging anatomy of the oral cavity. So in this presentation, I'm going to talk about the oral cavity, anatomy of the oral cavity, and what is the oral cavity exactly? It's an area in the head and neck, which is the most proximal part of our aerodigestive system. And as such, it plays an important role in breathing, eating and drinking, speaking, and it even contains one of our senses, namely taste. How to situate the oral cavity in the bigger head and neck anatomy? Well, as said, it's the most proximal part of the aerodigestive system. On top of it, or superiorly of it, we find the nasal cavity, which is the most proximal part of the respiratory system. The oral cavity communicates with the pharynx, which has a muscular tube which directs food from the oral cavity to the esophagus and air from the nasal cavity or the oral cavity to the larynx and the lungs. And the larynx finally as a cartilaginous system located between the pharynx and the trachea. Okay, in this presentation we're going to focus, as said, on the oral cavity, but those other areas will become topics of presentations in the future. But when exactly, I cannot say, as usual. What are the anatomical borders of the oral cavity? Anteriorly, we have the lips and cheeks. The cheeks are situated more laterally, so I can't show them on this sagittal image, of course. The inferior border of the oral cavity is formed by the so-called floor of mouth. And the most important component of the floor of mouth is the mylohyoid muscle, but more about that later. The superior border of the oral cavity is formed by the hard palate, and the posterior border is formed by, well, basically the posteriorly of the oral cavity we find the oropharynx, but the border exactly I cannot show you on this sagittal image. Why is that? Well, let's look at how the border is defined. To see the border between the oral cavity and the oropharynx, we would have to look in the mouth of a patient. We would have to ask a patient to say ah, look in his mouth, and then basically the border between the oral cavity and the oropharynx is formed by the oropharyngeal isthmus, which is basically the opening we can see visually, the small gateway connecting the anterior oral cavity with the posterior oropharynx. And anatomical landmarks here or the superior border of this oropharyngeal isthmus is the uvula of the soft palate, here shown with the arrow. The inferior border is formed by the tongue base, more specifically the terminal sulcus, but I will illustrate that on the next slide. And the lateral borders are formed by the anterior tonsillar pillars. So those are all areas or things we can see when clinically inspecting a patient, but are more difficult to appreciate on imaging studies. For instance, the base of the tongue is difficult to recognize or distinguish on imaging. We can kind of suspect where it is located. It's the most posterior part, but we can't really see it. Why? Because anatomically, the difference between the oral tongue, located in the oral cavity, and the tongue base, located in the oropharynx, is determined by the circumvallate papillae. And those are a group of about 8 to 12 large papillae containing the taste buds for the bitter taste, and they are arranged in a V shape, forming a boundary between the anterior oral tongue and the posterior tongue base. So posteriorly of those large papillae, we find a depression called the terminal sulcus, and this is a bit wrong because it's V-shaped and the apex is pointing posteriorly, but yeah, that's just a detail. And then we have the oral tongue anteriorly and the tongue base posteriorly. And this is more than just an academic difference because those two parts of the tongue have a different sensory innervation. But I will talk about the sensory innervation of the tongue a little bit later in this presentation. Now, as said, we can't really see that. So how do we define the posterior border of the oral cavity? Let's recap. The anterior border is easy, the lips, inferior border, the floor of mouth with the mylohyoid muscle, then the hard palate is the superior border, and we kind of infer the oropharyngeal isthmus by drawing a line from the transition of the hard palate to the soft palate to the tongue base and hyoid bone. And we kind of infer that everything located in front of that line belongs to the oral cavity, and everything located posteriorly of that line is part of the oropharynx. So it's cheating a bit, it's not 100% correct, but it works in practice, and that suffices. Okay, now the oral cavity can be divided in two compartments. We have a very small compartment called the vestibule, which is located between the inner side of the lips and cheeks and the alveolar process of the maxilla and mandibula containing the teeth. So it's basically this very small area between your lips and your cheeks on the inside and your teeth on the outside. Then we have the oral cavity proper, which is basically the largest part of the oral cavity and is the large space located behind the teeth, extending to the oropharynx. This is another example. Don't really know what I'm going to show on this slide. Oh yeah, we can also divide the oral cavity in specific subsites, and this will be important because you can have all these subsites are covered with mucosa, and this mucosa can give rise to squamous cell carcinomas. So these can all be locations for oral cavity cancers. So what are those locations? Once again, the lips are covered in mucosa. We have the buccal mucosa, the mucosa lining the cheeks, but we can't see the cheeks on this mid-sagittal image, of course. They are situated more laterally. Then we have the alveolar ridges of the maxillar and mandibular bone containing the teeth sockets and the teeth. And these are also covered in mucosa, and we call that area, the mucosa covering the alveolar ridges, we call those the gums, the gingiva. Then all these are part of the vestibule. So when it comes to the alveolar ridges, let's say it's the most anterior part, and everything located behind that is then part of the oral cavity proper. And what do we find there? We find the hard palate, also part of the alveolar ridges, of course, with the gingiva. So we find the hard palate, we have the oral tongue, we have the floor of mouth, and I exaggerated it a bit, should be a lot smaller on this drawing, but never mind that. And we also have a very small region called the retromolar trigone. But despite the fact that this is a very small mucosal area located behind the last mandibular molar tooth, can't see it on this image, but I will illustrate it later in the presentation. Despite the fact that it's a very small area, it's a very important one, because when you get cancer over there, it can quickly spread to other areas of the head and neck. Okay, so let's work with this anatomical subdivision to illustrate the imaging anatomy of the oral cavity. So let's start in the vestibule, and this drawing, which I generated with Chat GPT, kind of illustrates the vestibule. So if you want to have an idea, what is that exactly, the vestibule? Just clench your teeth and, pull open your mouth using your fingers, and that area between your lips and your cheeks and your teeth is the vestibule. So that a very small space between your cheeks and lips on the outside and your teeth and gums on the inside. And despite the fact that it's small, it contains mucosas, and wherever we have mucosa, we can get squamous cell carcinomas. It contains the mucosa of the lips and cheeks, also the outer sides of the gums and teeth. And also opening here is the parotid duct, which opens opposite the upper second molar tooth, and which is important for keeping the vestibule moist. As said, despite the fact that this is a very small area, this is a recognized site of oral cavity cancer, especially in patients that, for instance, chew tobacco. And this makes sense because in the vestibule, it's a very small area, but we when we chew things, we push things from the oral cavity into the vestibule and back again. So when you do that with carcinogenic substances like tobacco, it kind of makes sense that you have an increased risk of developing cancer in that very small area. And it's difficult to see because everything in a normal situation, this is an axial CT of the neck with contrast, Well, the mucosa of, let's say, the outer side of the alveolar ridges, the teeth, the gingiva, and the inner mucosa of the lips and cheeks, it all lies opposed to one another. So it's kind of difficult to evaluate our structure and detail. So this has to be the vestibule. We see soft tissue located superficially along the outside of, in this case, the mandibular teeth. Um, this is another example, and we find two important muscles in the vestibule. We find the orbicularis oris muscle in the vestibule, and I've illustrated it here. And this is basically like a sling-like muscle aligning your mouth, located inside the lips, and also giving, basically constituting the bulk of the lips. It's a small muscle. It's an important muscle because we need it to close our lips, to seal our lips. Any movement we make with our lips comes from the orbicularis oris muscle. And then a second muscle, which is located at the vestibule, is the buccinator muscle, which is basically the muscle located in the cheeks, laterally of the cheek mucosa. We can see it on imaging, despite the fact that it's a small muscle. And this muscle is important for instance, sucking, blowing. When it contracts, we kind of compress the inner sides of our cheeks. Okay, these small muscles are located in the vestibule and are recognizable on imaging. We can, as said, develop cancers or pathology in the vestibule, despite the fact that it's a very small structure. And do you see the lesion in this patient? If you look carefully, you will see a contrast-enhancing lesion located over here on this coronal T1 weighted image with gadolinium and fat saturated. It's located. It seems to be located between the buccinator muscle over here laterally and the mandibular alveolar ridge and teeth. We can also see it on this axial image. And now the question is, well, where does this lesion originate from? This was cancer, squamous cell cancer. Does it originate from the buccal mucosa or from the gingiva? Now, it's basically impossible to say on this image because these structures lie immediately opposed to each other or opposed to each other. So impossible to say. There's something you can do, and it's easier to do it on a CT, and that is use the puffed cheek technique. Ask a patient to puff his or her cheeks. This is an image I took from the medical literature because we don't often do that, because we don't often get even if patients have small lesions or tumors in that area, it's not always given in the clinical information, and you have to know it to do it. So we don't do it on a routine basis. But if you do that, you can clearly distinguish the mucosa lining the inner side of the lips from the buccal mucosa and the gingival mucosa. And the vestibule is now expanded and filled with air, as you can see. And this technique can be useful to detect very small lesions originating from the gingival, buccal, or labial mucosa, as we can clearly see here in this patient, and this was another example I took from the medical literature. So remember it, the puffed cheek technique. If you ever get a request to examine a lesion originating from the mucosa of the cheeks or the outer gingiva, use the puffed cheek technique on your CT to better visualize it, because otherwise it can be difficult. Now, let's move to the oral cavity proper, and my apologies for this illustration. So normally I generate my images with ChatGPT, but I don't have a paid subscription, and after a while I can't generate new images for my presentation. So I made a selfie. I tried to, I manipulated it a bit, but basically this is just to illustrate the oral cavity proper. So the vestibule is clench your teeth and pull open your cheeks. To see the oral cavity proper, just open your mouth and say ah, and we have a nice clinical view of the oral cavity proper. So once again, my apologies for this picture. The oral cavity is, as said, the main room inside our teeth where the tongue and most structures of the oral cavity can be found. As such, the most important one is no doubt the oral tongue, but also important are the floor of the mouth, the hard palate, the retromolar trigone, very small structure, but very important, and also the inner side of our teeth and gums, also belonging to the oral cavity proper. Let's start with this structure over here, the tongue. And the tongue is an important structure. As said, part of it is situated in the oral cavity and is the oral tongue. The part of the tongue situated in the oropharynx is the tongue base. And it's not really possible to see the border. As said, the border is determined by the terminal sulcus, located, a small depression located between the circumfallate papillae. We can't see it, but we can guess a bit where it is approximately situated by drawing a line from the border between the hard palate and the soft palate to the tongue base on sagittal images. And it would probably approximately be situated over here a bit. Okay, it's not really that important for this presentation. These are T2 and T1 weighted images. This is the tongue, and well, this is a very classical and characteristic appearance. The tongue has kind of this very marbled appearance. We see some fatty tissue giving it a somewhat heterogeneous T1 hyperintense appearance. We also see muscular fibers, but they seem to be going in different directions. And that is because the tongue is a very muscular structure, composed of muscles with fibers interwoven with one another, running in different directions. So it's a bundle of intrinsic and extrinsic muscles. Intrinsic meaning that the muscles are completely situated within the tongue. So they don't have an origin outside of the tongue. They don't have an origin on a certain bone or a certain piece of cartilage or whatever. No, the muscle is completely located within the tongue itself. So the tongue and the extrinsic muscles have a certain origin outside of the tongue. Okay, the tongue is covered with mucosa, and it's a muscular structure that can change shape and move freely. And as said, it's extremely important for swallowing, speech, and taste. I already said this, so we have two groups of muscles in the tongue. We have the intrinsic tongue muscles that are not connected to structures outside of the tongue, and these are responsible for changing the shape of the tongue. We also have extrinsic tongue muscles. These are connected to certain structures outside of the tongue, and these alter the tongue positions. Why do you see an image of an elephant over here? Because the intrinsic tongue muscles do not have connections to anything outside of the tongue, and in that way the tongue resembles the trunk of an elephant, because the trunk of an elephant is composed completely out of intrinsic muscles. These are not connected to anything outside of the trunk, and they are responsible for changing the shape of the trunk. The comparison does not hold up completely because the tongue also has extrinsic tongue muscles, of course. Now, before showing you these various muscles, I'm going to illustrate the lingual septum, because this is a very important anatomical reference point. So the tongue is divided in two by a lingual septum. This is a midline fibroelastic septum, but it often has some fatty infiltration, or there's often some fatty infiltration next to it, which makes it easy to recognize as a fatty line dividing the tongue in two halves. This septum is present from the tongue dorsum to the hyoid. So the dorsum is here, the surface of the tongue, and it extends all the way to the hyoid bone. We can't really see the hyoid bone over here. And it is an attachment site for the intrinsic muscles. So here is the tongue septum. As said, the actual septum is a fibrous structure, and it's very thin, but we often see fatty infiltration next to it, causing it to give this midline structure a somewhat increased, giving it a high signal on T1. And it's an important structure because the fibrous septum is quite rigid. So if a lesion manages to cross the septum, so if you have like a lesion in one half of the tongue, but it extends a bit to the other side, crossing the septum, that means it has to be an aggressive lesion, because a benign lesion or a non-aggressive lesion will not easily cross the fibrous midline septum. So, okay, this can have some clinical implications if you see a lesion crossing the tongue. Let's now talk about the intrinsic tongue muscles, and I made a typo over here. This should be an S, of course. We have four muscle types. We have the superior longitudinal muscle located on the tongue surface superiorly, as you can see, and the fibers are running longitudinally towards us. When we have a superior longitudinal muscle, we also have an inferior longitudinal muscle, so located at the inferior surface of the tongue. Once again, longitudinal fibers running towards us and the coronal plane. And then we have like the bulk of the tongue, which is composed of transverse and vertical running fibers. So these are two muscle groups, the transverse muscle and the vertical muscle or the vertical fibers. And we can actually best of all see the transverse fibers here. And then here in the midline, we find most of the vertical fibers. So those are the four groups or the four intrinsic muscles of the tongue. When it comes to the extrinsic muscles, we have five, and well, let's say two of them are very easy to recognize, and those two are the geniohyoid. The geniohyoid runs from the chin, the midline of the mandibule, the inner side, to the hyoid bone, hence the name. And we also have the genioglossus, which also runs from the chin, the inner side of the mandibule, on the midline, to the actual tongue, the glossus. And these two together are sometimes also called the root of the tongue. So that's why I drew this plant over here with the root. Okay, so the geniohyoid and genioglossus, easy to recognize. We see the intrinsic tongue muscles here in purple. And then we have three other muscles that are a bit more difficult to recognize. We have the hyoglossus, originating from the hyoid bone. We have the styloglossus, originating from the styloid process, and we have the palatoglossus, the most difficult one to recognize, originating from the soft palate. Now, on this image, we can already see one of those extrinsic muscles, namely the hyoglossus, but I'm going to teach you how you are able to recognize it, because if I remove all these colors, admittedly, it's a bit more difficult to like say, ooh, this is going to be the hyoglossus. That's because I had the luxury of being able to scroll through the images and knowing how to localize it exactly. But before we illustrate those additional tongue muscles, let's also examine the tongue and the sagittal plane. I already indicated the hyoid bone on this sagittal T1 weighted image. And on the hyoid bone, we have an insertion of the mylohyoid muscle. And on top of the mylohyoid muscle, which is basically constitutes the floor of the mouth, as said, we find the geniohyoid. Because you can't really see the difference between the two on this image, both of them are colored in blue, but the mylohyoid muscle is the inferiorly located one, and on top of that we have the geniohyoid. But as said, we can't really see the difference on this image between the two. Then we have the genioglossus muscle, which, and we can appreciate that more at the sagittal plane, fans out to the actual tongue, to the glossus. And we see all these muscle fibers here basically radiating as a fan from the inner side of the mandibular midline. And then we find basically the bulk of the tongue containing the intrinsic tongue muscles. And of course, the inferior layer is constituted by the inferior longitudinal muscle. The superior layer is the superior longitudinal muscle. And then we have the vertical and transverse muscles located somewhat in between. And this meshwork, all these things, all these muscles combined, all these different orientations determine the very characteristic, somewhat marbled or interwoven pattern of the tongue, as we can see on MRI images. Remember, we have to draw a line from the transition area of the hard palate to the soft palate to the tongue base, because there's a difference between the oral tongue located in front of that line and the tongue base, which belongs to the oropharynx, as you already know by now. And what's the point of this slide? I cannot remember. I see a line showing us the difference between the oral cavity and the oropharynx, and I know what's going to happen. I'm going to show you an axial image at the level of the actual tongue, which mainly is composed of, or which is composed purely of the intrinsic tongue muscles at this level. And then I'm going to show you another axial image a bit lower at the level of the root of the tongue. And here we see the genioglossus, which has a very typical midline position. Here we see the base of the tongue, which is composed of intrinsic tongue muscles, and we can even see the hyoglossus, but it isn't indicated on this image, because now I'm going to show you how to find the hyoglossus. I already colored in the geniohyoid muscle and the genioglossus muscle for you. As you can see, geniohyoid in blue, genioglossus in like, I don't know, a bit yellowish. And to find the, oh, something went wrong, okay. And to find the hyoglossus muscle, well, it's easiest if you try to localize the hyoid. So this is a coronal T1 weighted image, strongly magnified, and I admit it's not that easy on MRI images, but this is basically the same structure as here, but a bit more posteriorly, and this is the hyoid bone. And originating on the hyoid bone is the hyoglossus muscle, which runs along the lateral surface of the tongue. So this structure here, clearly indicated by the arrows running along the lateral surface of the tongue to the hyoid bone, is the hyoglossus muscle. This is the most posterior slide. This is more at the middle level. This is relatively anteriorly. And we see that the hyoglossus, which is visible over here, more anteriorly, runs medially towards the genioglossus muscle. Let's now examine the hyoglossus. Here are the arrows indicating the location of the hyoglossus muscle. Let's now examine the hyoglossus muscle in the axial plane. Here is once again a coronal T1 weighted image with the hyoid bone, and here the hyoglossus muscle in the coronal plane. And in the axial plane, we find it over here next to the genioglossus muscle, but a bit more posteriorly. So this muscular structure over here next to the genioglossus is the hyoglossus and the axial plane. Okay, let's now illustrate the location of the styloglossus. This is becoming a bit more difficult or a bit more advanced head and neck anatomy, but it's not that difficult, because once again we just have to start from the origin, like from the hyoglossus muscle. After a while, you don't need to look up the hyoid. You immediately recognize it. If you're new to practice, look for the hyoid. Styloglossus, exactly the same. Look for the point of origin being the styloid process. So here is the styloglossus. Now, just showing you one image won't help you find it on your own. I know that. When you try to study head and neck anatomy from textbooks, it's always very frustrating, because then you see an arrow pointing to a very small structure and you're like, yeah, okay, great. But if I look at my images, I can't find it. I have no idea how to find it. Where is that thing? So how can you find the styloglossus muscle? Look for the styloid process. And you will have to believe me that this small thingy over here, indicated by the arrow, is the styloid process. So just believe me, it is. If you're able to scroll, you just look for the mastoid, and the styloid process is like this small bony extension on the undersurface of the mastoid and temporal bone. Okay, so this is the styloid process. And if we go one or two slices lower, we see two muscular structures originating from the tip of the styloid process. The most lateral one of those is the styloglossus muscle, and the most medial one of those is the stylopharyngeal muscle. And the name already indicates where those muscles are running to. The styloglossus muscle to the tongue, and the stylopharyngeal muscle to the pharynx, of course, in this case, to the oropharynx. Let's look a few slices lower, and here are the styloglossus and stylopharyngeal muscle, and some levels lower even, we can see them entering. Here we see the styloglossus muscle in yellow. We see it running towards the fleshy tongue over here. And here we see the stylopharyngeal muscle running to the palatine tonsillar region over here to the oropharynx. Okay, we're almost there. Final muscle, this is the most difficult one, a very small one, very difficult to detect, and well, it's very academic because from a clinical point of view, you rarely need to be able to localize this muscle. But hey, it's cool if you can do it, and for the sake of completeness, I'm going to show you where you can find the palatoglossus muscle. Once again, palato, palate, it originates from the soft palate. So let's magnify this axial T1 weighted image with gadolinium and fat suppression. And this structure over here is the uvula of the soft palate. And if you look laterally of the uvula, we find the palatine tonsils. And it looks a bit difficult, but on the other side, the enhancing structure in the middle, these are the actual palatine tonsils, and located anteriorly of it, we find this linear, somewhat darker structure. This is a muscle. This is the palatoglossal muscle, and the palatoglossus muscle is the muscle located or covered by the mucosa of the anterior tonsillar pillar. We also have a posterior tonsillar pillar, and underneath the mucosa of the posterior tonsillar pillar, we find the palatopharyngeal muscle. So, okay. Oh, what's happening? Okay, so that's the palatine tonsil. So here we find the palatoglossus and here the palatopharyngeus. So it's not easy. It's not easy, and you can't always recognize them in each and every patient. So this is just to give you an idea. And if you really want to, discover them on your own, this is how you have to try and find them. So look for the soft palate. Let's do it again, this time on a T2 weighted image with fat suppression. This is the uvula of the soft palate. We see the tonsils, the tonsillar region, laterally of it on both sides. We see that the palatine tonsils are higher in signal on T2, but we also see these dark muscular structures anteriorly, but also posteriorly. The anterior line is the palatoglossus muscle. Okay, and this is the muscle located in the anterior tonsillar pillar. Sorry if I'm repeating myself, but repetition helps to memorize things, especially for myself. I'm doing this. And this is the palatopharyngeus muscle located in the posterior tonsillar pillar. And well, this is an exceptional case, but I was even able to discover them. You can't do that in every patient, but in this particular patient on a sagittal CT image. This is here is the palatine tonsil, okay. This here is the uvula, but the lateral aspect of the uvula or the soft palate. And this muscle over here, or this line, is the palatoglossus muscle, and the posterior one running to the oropharyngeal wall is the palatopharyngeus. And see that this line runs towards the tongue. So this is the palatoglossus. As said, clinically, you will rarely encounter a situation where a visualization of the palatoglossus is absolutely necessary, but it's just cool to know these things. So I love anatomy, so I always find it very cool to be able to recognize these very small muscles or nerves or arteries or whatever. Okay, we're almost done with the tongue. Let's talk about the innervation of the tongue. It's basically quite simple. When it comes to motor innervation, all tongue muscles are supplied by the hypoglossal nerve, so the 12th cranial nerve, except for the palatoglossus, which is supplied by a pharyngeal branch of the vagal nerve or the 10th cranial nerve. So all are supplied by the hypoglossal nerve, except for the palatoglossus, which is supplied by the vagus. When it comes to sensory innervation, it's a bit more complicated. As said previously, there's a difference between the oral tongue and the tongue base. The oral 2/3 of the tongue are supplied by well, basically two nerves. When it comes to general sensation, for instance, pain, temperature, that is supplied by or done by the mandibular branch of the trigeminal nerve, more specifically the lingual nerve. When it comes to taste, taste innervation is by the facial nerve by way of the chorda tympani. Now, when it comes to the tongue base, the dorsal part, it's very easy. Both general sensation and taste come from the glossopharyngeal nerve or the ninth cranial nerve. And that concludes tongue anatomy. Let's continue with the floor of the mouth. The floor of mouth is the part of the oral cavity located underneath the tongue, between the oral mucosal surface and the mylohyoid muscle sling. It's clinically a structure that is actually quite difficult, very small and quite difficult to see. You basically have to ask your patient, and this time it's not a picture I took from my own mouth. It's something I pulled from the internet. You basically have to ask a patient to open his mouth and pull up his tongue, and then you can see the mucosa of the floor of the mouth. Now, on imaging, we can't really see this mucosal area because everything is located on top of each other, but we can distinguish the borders and the components of the floor of mouth. And those are, well, in the floor of mouth, we find various muscles, and the most important one is the mylohyoid, which basically constitutes the diaphragm of the floor of mouth. We find salivary glands, more specifically the sublingual gland is located underneath the mucosa of the floor of mouth, but also part of the submandibular gland. We have a specific space in the floor of mouth, the sublingual space, which of course consists or contains the sublingual gland, and we find specific nerves and vessels over there, also located in the sublingual space, by the way. When it comes to the muscular structure of the floor of mouth, which one should you definitely know? Well, of course, the mylohyoid muscle. The mylohyoid muscle is a muscle that inserts on the hyoid, of course, posteriorly, mylohyoid, but also on the inner surface of the mandibule. There's like a mylohyoid line on the inner surface of the mandibule, and that's where it inserts on. And it has a free posterolateral edge. So the posterolateral edge of the mylohyoid, well, it just stops and doesn't insert on anything. So there's an open posterolateral border there. Then on top of the mylohyoid, we find the geniohyoid. So the geniohyoid, we already talked about it when talking about extrinsic tongue muscles. Some authors consider it part of the floor of mouth, and it's located on top of the mylohyoid, and it's not always easy to see the border between the two. So it's a bit of guesswork. So this is going to be mylohyoid, this is going to be geniohyoid, and underneath the mylohyoid, and also often considered part of the muscle sling of the floor of mouth, we find the anterior belly of the digastric muscle. So the digastric muscle also has a posterior belly, but that's not located in the oral cavity. Here we also see, but we already know that the hyoglossus muscle in green. Now, on these coronal images, I'm just scrolling from anterior to posterior to show you the anatomy of the mylohyoid muscle. So here we see the mylohyoid muscle connected in the midline. In the midline, we have some kind of fibrous raphe, and it is inserts on the inner surface of the mandibule, as you can see, and we have the geniohyoid on top of it, and the anterior bellies of the digastric muscle underneath it. And if we just scroll through these various images, we see the mylohyoid. Here we see it inserting on the hyoid bone, and as said, the whoops, what's happening? Oh, my mouse is doing something crazy. Okay, it works again. And here the most posterolateral edges don't insert on anything, so there's just an open ending over there. And underneath the mylohyoid muscle here, we find the submandibular glands. Now, the submandibular glands are not part of the oral cavity. It's a space, a head and neck space, located underneath the mylohyoid muscle, except that, as said, the posterolateral edge doesn't doesn't insert on anything. And as we will see, the submandibular glands also extend a little bit over the posterolateral edge of the mylohyoid muscle. So they extend a little bit in the oral cavity, but we will see that on an axial slice. And this is that axial slice already. So here we have once again the mylohyoid muscle. Here are the anterior bellies of the digastric muscle, the geniohyoid, the hyoglossus, and now let's localize all these things in the axial plane. Oh, and this is the sublingual space, but more about that later. So the sublingual space is located on top of the mylohyoid muscle next to the genioglossus. Here we have the mylohyoid. Here is the genioglossus muscle. This is the hyoglossus muscle. This is the sublingual space containing the sublingual gland. And this boy over here is part of the submandibular gland. So the submandibular gland also has a deep component which extends a little bit into the oral cavity, and this also makes that the submandibular space can communicate with the sublingual space and with, by consequence, with the oral cavity. And it's important to know that this connection exists because it also means that pathology can spread from the submandibular space to the oral cavity or the other way around. Now, what are the components of the sublingual space? I think this is just about the anatomy. I already said that the sublingual space is located above the mylohyoid muscle, below the mucosa of the tongue. Medially, we find the genioglossus and geniohyoid muscles. Laterally, we have the mandibule, and posteriorly, you can see that on this image, it communicates with the submandibular space. Already said that. And it contains the sublingual glands, but also various nerves and vessels, but also Wharton's duct or the submandibular duct. So the submandibular gland extends a tiny weensy little bit posteriorly in the oral cavity, but then its duct courses all the way through the sublingual space to open anteriorly in the oral cavity in the floor of mouth. Then we also have the lingual nerve, so the branch of the mandibular nerve responsible for general sensory innervation of the anterior 2/3 of the tongue. We have the hypoglossal nerve running posteriorly in the sublingual space, responsible for motor innervation of the tongue, and we have lingual arteries and veins responsible for the vascular supply and drainage of the tongue. Can we recognize all these structures? Well, some of them are very small, so we can't really recognize, for instance, the lingual nerve. Maybe with some advanced MRI techniques you can, but in the majority of cases you won't. But you can kind of guess where it is approximately located. So the sublingual gland, which enhances, is located laterally in the sublingual space. And typically we can't see that on a CT image, but you can kind of infer its location. Wharton's duct is located medially of the sublingual gland. Now, the lingual nerve typically starts superiorly and laterally of Wharton's duct, but then crosses it and goes underneath it to go inferiorly or run inferiorly and medially in the sublingual space. Now, the hypoglossal nerve is located more deeper and inferiorly than the lingual nerve, and also more posteriorly in the sublingual space. And then we finally have lingual arteries and veins, and the most medially located are the lingual arteries. They are typical, or the lingual artery, which is typically located medially of the hyoglossus muscle. This is a coronal T1 weighted image with gadolinium and fat suppression, and this is a magnification. And this enhancing structure over here is the sublingual gland. We can also see part of the mylohyoid muscle over here, so it's located on top of that. So Wharton's duct has to be located somewhere over here. The lingual nerve has to cross it and run a bit like this, probably. This is just guesswork. And this structure over here is either a lingual vein or the lingual artery. If it's located laterally of the hyoglossus, it's the lingual vein. If it's medially of the hyoglossus muscle, it's the lingual artery. We're almost there with the floor of mouth. This is an axial T2 weighted image with fat suppression. This is a magnification. And here we see, oh, my mouse is doing something crazy again. This is the submandibular gland. This here is the sublingual gland. And this linear structure, which is hypertension on T2, is Wharton's duct. So it's not always easy to recognize, especially when it's not dilated. So when there's an obstruction, for instance, because of a cyalolithiasis, it can become distended, and then it's more easy to recognize. When it's normal, it's thin, difficult to see, but we see it over here. And you also see that it courses medially of the sublingual gland. And this is the same patient. This is an axial T2-way, or well, proband. This is an axial T2 weighted image. This is a high resolution T2 weighted image, a MIP reconstruction I made, and we see the Wharton's duct running in the sublingual space, and it opens anteriorly in the floor of mouth. Okay. This is a picture I took from an article from Radiographics to illustrate the relationship between the submandibular gland and the sublingual gland in the oral cavity. So we start with the mylohyoid muscle as point of reference. The sublingual gland is located on top of the mylohyoid muscle. The submandibular gland is for the most part located underneath it, but at the free edge, it extends a bit into the oral cavity and communicates with the sublingual space. Then we have Wharton's duct. This is the submandibular gland. Then we have the submandibular duct or Wharton's duct, which runs medially of the sublingual gland to open anteriorly in the floor of mouth. And when it comes to the submandibular gland, or the sublingual gland rather, this doesn't really have one opening. There are a lot of tiny openings by the sublingual ducts, and these are called the ducts of, what's it again? Riviera? I can't remember. So let's just call them the sublingual ducts, and my apologies to the brilliant anatomist who gave these ducts his or her name, probably his name. Not because women would be able, but because historically speaking, most anatomists were men, due to the fact that women were often refrained from studying medicine or doing medicine, and that was definitely an injustice, but enough about that. Times have changed, was probably his, but never mind. Okay, enough trying to be politically correct. Let's talk about the hard palate. Now, the hard palate is the superior surface of the oral cavity, and it basically separates the oral cavity from the nasal cavity. Posteriorly, we have the soft palate, but the soft palate is located in the oropharynx, and the hard palate is located in the oral cavity as said. Now, it contains the incisive foramen, which is and it also contains the greater and the lesser palatine foramina. Of those foramina, I'm just going to show you the incisive foramen, which is an opening located anteriorly and the palatal bone, and easy to recognize on both sagittal and axial images. So this is sometimes also called the nasopalatine foramen, and it contains the deeper palatine artery and veins and the nasopalatine nerve, which is the branch of the maxillary nerve. I might do a future presentation on all these small foramina and all these nerves and so on. But for now, because you can recognize this canal on and basically any patient without much difficulty, I'm showing it to you, the incisive foramen or the nasopalatine foramen. This structure is very important. So maybe a little bit more about the hard palate, because I went, the hard palate is also covered in mucosa, of course, so you can have squamous cell carcinomas of the hard palate. Also, the hard palate contains a lot of minor salivary glands, and as you know, tumors originating from minor salivary glands are often aggressive. So it's also a spot for the development of possible salivary gland or aggressive salivary gland tumors. Okay, final region, and an important one when it comes to anatomy of the oral cavity, is the retromolar trigone. The retromolar trigone is a very small triangular mucosal area which is located posteriorly of the last mandibular molar tooth, immediately in front of the anterior border of the mandibular ramus. Okay, so small area. Why is it important? Because underneath the mucosa of the retromolar trigone, we find a structure called the pterygomandibular raphe. And the pterygomandibular raphe is responsible for this somewhat, bulky appearance of this region. And this is basically a fibrous structure on which two important muscles insert, namely the buccinator muscle, and we already know that one. So here, this is the cheek, and the buccinator muscle is located underneath the mucosa of the cheek. Here we see the tongue. This is the oropharynx over here. Here we see the palatine tonsil. So this is going to be the anterior tonsillar pillar. Anyways, underneath this mucosa, we also have a muscle called the superior constrictor muscle. Now, why is this all important? Because if you get a tumor of the retromolar trigone, this will quickly invade the pterygomandibular raphe and can then spread along the buccinator to the masseter space or along the superior constrictor muscle to the parapharyngeal space. So this is basically a highway to other head and neck spaces. And when a tumor originates in this area, it can quickly spread to these other areas. And that's why it's a very important area, despite the fact that it's small. So this is illustrating the anatomy of the retromolar trigone on an axial T1 weighted image. Here we have the last mandibular tooth. Here we have the mandibular ramus. And the retromolar trigone is located over here, so between the last mandibular tooth and the mandibular ramus. When you get a tumor over there, as said, but it helps to see the anatomy now, we can kind of understand why it can quickly spread to either the masseter space or the parapharyngeal space. Yeah, if you look at it this way, it's kind of self-evident, I believe. And that's why you should always scrutinize this area on CTs or MRIs of the neck. Nevertheless, even if you scrutinize them, you should be very careful because the tumors can be small and easy to miss. Let's magnify the CT image with contrast of the oral cavity region. And on the right side, nothing out of the ordinary. We see the last mandibular tooth over here and the mandibular ramus, and this is the normal trigone. But here we see a contrast-enhancing structure. This was a retromolar trigone tumor. This was a squamous cell carcinoma of this area. Here's the same patient in the coronal plane, also very difficult and easy to miss. Here is the tumor located, and a giveaway or something that should make you really scrutinize your images for a possible tumor in this region would be the presence of this central necrotic lymph node located in the submandibular space on the ipsilateral side. And here is the axial image again, illustrating this retromolar trigone tumor. Okay, I believe that with the retromolar trigone, we have covered all important areas, anatomical areas of the head of the oral cavity. What do I want you to remember? Because it was probably a lot, and not everything is as important. If you are now able to recognize the palatoglossus muscle in each and every patient, excellent, good for you. But as said, it's not always that important. So what I do hope is that after this presentation, you are now able to quickly recognize the main components of the floor of the mouth and the tongue, like the mylohyoid, the anterior bellies of the digastric, the geniohyoid, genioglossus, hyoglossus, the intrinsic muscle, sublingual space located over here. That is easy both in the coronal plane and the axial plane. So here in the axial plane, we see the genioglossus. Here is the mylohyoid, hyoglossus. This is the tongue base, and here we have the submandibular gland. And as you know, Wharton's duct runs medially of the sublingual glands located over here, or the sublingual spaces with the sublingual glands. Why is this important? Now your boundaries. Why is it important to know oral cavity anatomy, but also to make a clear distinction if a lesion between a lesion located in the oral cavity and a lesion located in the oropharynx, because tumors here behave different, they have different treatment regimens, and they have a different prognosis. So it's very important to clearly indicate the location of a tumor and clearly indicate if the tumor is located in the oral cavity or the oropharynx. Also, tumors can occur anywhere in the oral cavity because all structures are covered with mucosa, even in the small vestibule. So small regions are important. Small regions, big pathology. This is a typo. So always examine the retromolar trigone, but also the vestibule, despite the fact that it's often difficult because you can't clearly distinguish the buccal or labial from the gingival mucosa. And as said, why is this important? Because you can get oral cavity cancer in each of these subsites. So check all these subsites, the lips, the oral tongue, the floor of mouth, retromolar trigone. Also look at the alveolar ridges, which are covered by mucosa, the gingiva. Look at the buccal mucosa and the vestibule, and look at the hard palate for possible tumors. And a future presentation will involve how to stage oral cavity tumors. But to do that, you first have to know oral cavity anatomy. I hope with this presentation I succeeded in illustrating oral cavity anatomy, and I also made it understandable, easy, and not too dense. I hope you learned something from this. If you have any questions, comments, or feedback, please send me an email, neuroradiology.online@gmail.com, or leave a message in the message section. Thank you very much for watching.